And you're live.
Great. It's first of all, welcome everybody. Hope everybody had a fantastic break. It is my great pleasure to introduce Dr. Jessica Kraft, who is a postdoctoral scientist working at Dr. Kristen Kennedy's lab. She earned her PhD in neuroscience in 2023 from the University of Florida, where she conducted research in Dr. Adam Wood's lab. Small world. Her doctoral work focused on exploring the effects of transcranial direct current stimulation, non-invasive brain stimulation techniques, combined with cognitive training to enhance cognition in older adults. Additionally, she has extensive experience as a neuropsychological testing coordinator, administering assessment to evaluate frontotemporal dementia. Very lucky to have her here, telling us all about what she's been working on here.
Well, thank you. That warm introduction. As Dr. Ruffin mentioned, my name is Jessica Kraft, and I'm going to start today's talk titled Bridging the Gap, Integrating Clinical Trial Insights and Longitudinal Neuroimaging Studies, discussing some of my previous research that I did at the University of Florida before coming to CBL. And then I'm going to segue into some current work in the second portion of my talk. But I want to start off with a little bit of personal background to frame this talk and what ultimately shaped my research interests. So in this slide are two women in my life. The woman on the left is my aunt, and the woman on the right was my grandmother. Both of these individuals lived well into older age, one with a neurodegenerative disorder, with little to no noticeable decline in cognition. So I wonder, what is it about certain individuals that makes them resilient to cognitive decline, whether throughout the course of neurodegenerative disease or healthy aging? More importantly, can we augment this cognitive resilience or at least slow down cognitive decline as we age? And while the previous two examples are anecdotal, there's quite a bit of evidence suggesting that age and neurodegenerative pathology are not entirely indicative of cognitive decline. So for instance, one individual may show no amyloid plaques in the brain and show normal cognition, indicated by the black circle here and the first row of brain scans to the right. Whereas another individual may show high levels of beta amyloid, yet still be within the normal ranges of cognition, as shown by the green circle here and second row of brain scans. So given these individual differences, I wanted to know, can we find an effective intervention method to delay cognitive decline? With these questions in mind, I joined the lab of Dr. Adam Woods in 2017, and the lab focused primarily on non-invasive interventions such as neuromodulation to potentially slow cognitive decline in older adults. So I'm going to start off this talk with a brief background of TDCS, the main neuromodulation technique that we used in the lab. Then I want to highlight 3 of the studies that I was involved in during my time there, as well as my dissertation work. And then I'm going to end with some current research being done here at CBL. So to give a brief introduction on transcranial direct current stimulation, or TDCS, TDCS is a safe, non-invasive neuromodulatory technique in which a constant weak electrical current is delivered to underlying brain tissue via electrodes placed on the scalp. This weak electrical current is generally on the order of 1 to 3 milliamps, with current directed through a conductive medium, usually saline sponges or a conductive paste. And this current flows from the anode to the cathode, as seen here. The resultant current flow has been shown to penetrate skin, skull, and meninges, and has been shown to alter resting membrane potential. We can tailor the TDCS montage using the 1020 EEG measurement system to localize areas of the brain that we wish to target. Substantial evidence has demonstrated that TDCS has the ability to alter resting membrane potentials by strengthening or dampening cortical excitability, depending on stimulation parameters. It's important to note that unlike transcranial magnetic stimulation, or TMS, TDCS does not directly invoke action potentials. Rather, TDCS modifies subthreshold resting membrane potentials, thereby altering neuroplastic response of cortical and subcortical tissue. More importantly, the induction of resting membrane potential changes via TDCS have been shown to last on the order of several hours or longer. Although the mechanisms through which TDCS alters long-term neuroplastic response are not definitively known, research suggests that TDCS elicits long-term potentiation or long-term depression-like effects through activations of NMDA receptors, whereas acute effects of TDCS are thought to be sodium and calcium channel dependent. It's imperative to note that TDCS effects do not occur in a linear fashion. Research has shown that stimulation at 1 milliamp and 3 milliamps result in depolarization of neurons under the anode and hyperpolarization of neurons under the cathode. Counterintuitively, stimulation at 2 milliamps for 20 minutes has shown to cause depolarization under both the anode and cathode, likely due to alterations in calcium concentrations. These findings are of an exceptional importance in using TDCS as an intervention in slowing cognitive decline, as the aim would be to increase cortical excitability rather than to inhibit it. Thus, our goal was to use these parameters as a possible intervention in staving off cognitive decline. One of the first studies I worked on in the Woods lab was the CogStim study, spearheaded by my colleague, Nicole Neeson. In this study, participants performed a 2-back task 3 times in scanner, 1 run at baseline, 1 run while receiving either active or sham TDCS in scanner, and 1 run following TDCS stimulation. For those who may be unfamiliar with the N-back task, participants will see stimuli one at a time presented on the screen, uppercase letters. They may, for instance, see the letter F and then the letter P. They must decide if the letter presented 2 back was the same or different than the stimuli. So this is different from the letter 2 back. This would be the same as the letter 2 back. This would be the same as the letter 2 back. So participants must update their working memory with each letter presented. In this study, active TDCS comprised of a 30-second ramp up phase, 12 minutes of 2 milliamp stimulation, and a 30-second ramp down phase. Sham TDCS comprised of a 30-second ramp up phase, 30 seconds of TDCS, and a 30-second ramp down phase. Previous studies have shown that participants attenuate to the sensation of TDCS within about 30 to 60 seconds, making it an effective sham. A priori regions of interest, or ROIs, for this study were selected from the Owen et al. 2005 meta-analysis, which identified 15 ROIs associated with the fMRI and backpack. ROIs were titrated to ensure non-overlap. So what did we find? Using a seed-to-voxel GPPI analysis, we found that those randomized to the active condition demonstrated an increase in connectivity between the left ventrolateral prefrontal cortex and left dorsolateral prefrontal cortex, or DLPFC, during completion of the NBAC test. Notably, those in the sham condition did not demonstrate this increased task-based connectivity. These findings demonstrate that not only can active TDCS alter functional connectivity, but doing so in conjunction with the task activating that network results in additional gains compared to baseline and post-activation NBAC. Thus, optimal gains from TDCS may be achieved by co-stimulating neural networks through both cognitive tasks and through electrical stimulation. It should be noted, however, in this study, there was quite a bit of variability in TDCS outcomes, and we wanted to investigate why some individuals responded to TDCS outcomes where others did not. So if you remember, TDCS is delivered to underlying brain tissue via electrodes placed on the scalp. However, current flow will change drastically depending on the medium that the electrical current is flowing through. And of course, anatomical differences can differ widely between individuals. So in this study, led by Dr. Prinda Indulasturi, we set out to quantify the amount of current flow to underlying gray matter in the brain using individualized finite element models. In other words, modeling all tissue types. All right. 6 of our 12 tissue types were produced using SPM and ROAST. And while ROAST is a program that provides semi-automated results, these results often need manual intervention. So here we see the output of ROAST cortical bone registration. While it captures the overall shape of the skull, we see some substantial errors where it classifies CSF and brain as skull. Thus, following rows, we manually edited the masks for accuracy. The remaining 6 tissue types were manually segmented voxel by voxel using the T1 image to segment fat, muscle, blood vessels, air and sinuses, electrode paste, and the sclera and lens of the eye. We further separated the skull into cancellous bone or spongy bone and cortical bone or compact bone, given their distinct conductivity values. This is crucial in older adults since bone degradation or osteoporosis will cause the bone to be more porous or spongy. For context, each participant's segmented head model took approximately 30 hours of manual segmentation. So for those who think free server is bad, much worse. While time-consuming, these segmented head models allowed for the most accurate current density maps possible. Typically, TDCS is thought of as a one-size-fits-all model. You inject a dose of 2 milliamps of current, and the underlying tissue receives 2 milliamps of current with no individual differences whatsoever. Of course, this is not the case. Even just based on visual inspection, we can see that participant 5, for instance, has much greater current density than participant 1, even though the same electrical current is injected in the same 1020 EEG space. Additionally, although neuromodulation modeling toolboxes include electrode placement, the electrodes are artificially placed in their ideal location rather than the location that was used during TDCS stimulation. So for instance, the cathode on participant 3 appears to be more lateral than other participants. This is important to note because shifts in electrode location as little as 1 centimeter have been shown to have a profound effect on the delivery of current dose in the brain. So using these individualized current density maps in conjunction with the NBAC task-based functional connectivity data that I showed, we can see that there's a significant relationship between current density and beta values in the DLPFC, where we see no relationship between current density and DLPFC beta values. So the next question we had was, does this have real world implications? Does current density matter in terms of cognition? And in brief, yes, it does. Following this work, we found that median current density was directly associated with NBAC performance. Specifically, the individuals who had the greatest change in TVAC performance, calculated as a change between reaction time and accuracy, post-stimulation compared to baseline, were also the individuals that had the greatest median current intensity reaching the cortical tissue. So these results were exciting preliminary findings for using TDCS to improve cognition. However, the previous CogStim study took place over a single scanning session using one working memory paradigm. We wanted to see if we could extend the effects of TDCS longer by using a combined TDCS and cognitive training intervention. So I'm not going to belabor the details of the study here, as the next study I'll be talking about, the ACT study, expounds upon this one. In brief, we recruited 30 older adults ages 65 to 89 for a 2-week TDCS and cognitive training intervention. Participants were randomized to 20 minutes of either active TDCS or to sham TDCS, with electrodes placed at F3 and F4, corresponding to the left and right dorsolateral prefrontal cortex, respectively. Participants completed 40 minutes of adaptive cognitive training during the 20 minutes of stimulation. All participants and experimenters were blinded to TDCS randomization. So following unblinding of the data, we found similar results to the in-scanner TDCS study. We observed strengthened task-based functional connectivity between the left DLPFC and right inferior parietal lobule in the active but not in the sham group when participants were completing the NBAC task. Additionally, we saw significant improvements in accuracy following the 2-week intervention during the TVAC task in the active but not in the sham group. And while the cognitive training incorporated working memory training, the NBAC in-scanner task was not the task the participants trained on, suggesting that this intervention may result in near transfer effects. Our lab was not the only one to find improvements in cognition using TDCS. A comprehensive meta-analysis looking specifically at older adults found that active versus sham TDCS showed demonstrable improvements in cognition. Cognitive improvement was demonstrated in numerous domains, including small to medium effect sizes in working memory, attention, and processing speed. We were also interested in investigating neurometabolic changes that may be occurring following this intervention using magnetic resonance spectroscopy, or MRS. Regarding electrical stimulation, if you remember from some of the current density maps, the area of greatest current density are between the anode, which is injecting current, and the cathode, which is pulling current. Thus, we placed our MRS voxel near the genu of the corpus callosum to try and capture the area of greatest current density. We found that following a 2-week TDCS and cognitive training intervention, those randomized to active TDCS demonstrated significant increases in GLX, or the combination of glutamate and glutamine, compared to those randomized to sham TDCS. However, we did not find the same pattern of results for GABA. These aligned with our hypotheses, given that 20 minutes of 2 milliamp stimulation has shown to be excitatory under both the anode and cathode. Glutamate is a primary excitatory neurotransmitter in the brain. Thus, collectively, these findings suggest that TDCS-based interventions can impact both cognition and neural biomarkers. Cumulatively, these studies lay the framework for the ACT study, which is the main study I worked on during my time in the Woods lab and the study that served as the basis for my dissertation. So what is the ACT study? It stands for Augmenting Cognitive Training in Older Adults. The study was the first ever phase 3 TDCS trial and largest still to date. We recruited 379 participants ages 65 to 89 over the course of 5 years. It was the largest cognitive training trial to investigate neural mechanisms using multimodal neuroimaging. This was a multi-site study in collaboration with the University of Arizona. Approximately 2/3 of the sample were recruited at the University of Florida, and approximately 1/3 of the sample was collected at the University of Arizona. Like the StimBrain study, this was a double-blind, randomized controlled trial, and all parties were blinded to TDCS allocation. Thankfully for the study, and most importantly my dissertation, we were able to complete the study in 5 years, even given the pandemic. Our first in-person screening took place in August of 2017, and unblinding occurred in June of 2022. So I'm going to start with an overview of the study timeline, as there's quite a few moving parts. Beginning with recruitment, participants were contacted via postcard mailings, flyers, newspaper advertisements, social media, and community outreach events. The study offered free transportation to participants located within a 40-mile radius of the study site in an attempt to address barriers associated with research participation. The phone screening was comprised of a brief overview of the study, followed by a series of questions regarding medical history to determine eligibility. Exclusion criteria include, but weren't limited to, being outside of the age range, having a history of neurological or severe psychiatric disorders, having any major medical condition that's not controlled by medication, being left-handed, or taking GABAergic, glutamatergic medications, or sodium channel blockers, as these can affect TDCS current flow and outcomes. At the beginning of the screening visit, a research coordinator reviewed the informed consent with participants to ensure participant understanding of the study procedures. Following consent to participate, participants completed questionnaires regarding their medical history and MRI compatibility, as well as a brief hearing and vision task. A neuropsychological battery, the Uniform Dataset, or UDS, was given to assess for possible mild cognitive impairment or dementia prior to study randomization. Participants were subsequently excluded following the screening visit if they were found to have impaired cognition based on the UDS battery, which was defined as 1.5 standard deviations below age, sex, and education-based norms. The baseline visit was typically split over 2 days and comprised of a 1-hour MRI scan, as well as a comprehensive cognitive battery and series of questionnaires. At the baseline visit, we collected T1, FLAIR, Megapress, and water reference scan for MRS, as well as 2 in-scanner tasks, the useful field of view task, and the NBAC task, as well as a resting state scan. Participants were scanned via 3T Siemens Prisma at the University of Florida or 3T Siemens Skyra at the University of Arizona. The NBAC task was identical to the one used in the StimBrain study. We used a variation of the useful field of view or UFOV task adapted for in-scanner presentation. This task is typically thought of as an attention and processing speed task. To start, participants see a fixation cross. They are then briefly presented with a stimulus screen in which they must attend to an object in the center box, either a car or a truck, and a car in the periphery presented amongst distractors. They're then shown a mask. And then finally, during the probe screen, they must decide if the object in the center of the screen and the location of the target outside the center box are the same as in the previously observed stimulus screen. Randomization for the study occurred immediately following the baseline visit prior to the first intervention visit. All randomization was performed by the clinical trial statistician, and all interventionists were provided a unique 6-digit code for each participant and were blinded to TDCS condition until completion of the overall study. So moving into the active versus sham TDCS intervention visits, study visits between active and sham TDCS were identical. Participants would come in once a day for 2 weeks for 20 minutes of TDCS plus 40 minutes of cognitive training at the same time. Following the first 2 weeks, participants would come into the lab once a week for the TDCS and cognitive training, and the other 4 days they would complete cognitive training at home on a laptop provided to them. At the beginning of each visit, participants are given a sensation questionnaire asking about any residual side effects from their last intervention visit, as well as their current health. The sensation questionnaire measured 11 possible side effects of TDCS on a Likert scale from 0, no sensation, to 10, extreme sensation. The side effects measured include tingling, itching, burning, pain, fatigue, nervousness, headache, difficulty concentrating, mood changes, changes in visual perception, and visual sensation. They were then given the same questionnaire about sensations during stimulation and after stimulation. So after this pre-stimulation questionnaire was completed, head measurements were performed to locate F3 and F4 using the International 1020 measurement system. The bilateral frontal TDCS montage consisted of the cathode placed at F3 above the left DLPFC and F4 above the right DLPFC. 2 5x-centimeter sponges were saturated with 10 milliliters of saline and encased the electrodes over F3 and F4. Electrodes were held in place via a rubber strap placed around the participant's head. To ensure proper placement of the electrodes, a 3D model of the head was taken prior to stimulation and then immediately after the 40 minutes of cognitive training at each intervention visit. These 3D models are used to calculate the accuracy of electrode placement during each intervention session compared to the absolute F3, F4 location. Following the first head model, once optimal impedance was reached, the interventionist would input this blinded 6-digit code into the stimulator. The stimulation session began concurrently with the start of cognitive training. The active stimulation consisted of a 30-second ramp-up phase, 20 minutes of 2 milliamp stimulation, and a 30-second ramp down phase. In contrast, the sham condition comprised of a 30-second ramp up phase, 30 seconds of 2 milliamp stimulation, and then a 30-second ramp down phase. Again, studies have shown that participants attenuate equally to the sensation of both active and sham TDCS after about 30 to 60 seconds and are unable to distinguish the 2 different types given these parameters. Our cognitive training intervention utilized a subset of the POSIT Brain HQ training suite, targeting working memory and processing speed. All participants engaged in 40 minutes of POSIT cognitive training 5 days a week for this 3-month intervention. Training sessions consisted of 4 tasks per day, randomized, lasting 10 minutes each. Following the first 2 weeks, cognitive training adherence was monitored remotely. The 3-month visit took place 72 hours within the final intervention visit. The procedures are identical to baseline, except for the post-intervention assessment of cognitive training gains and the expectancy questionnaire, which I'll go over next. By the time the 3-month visit occurred, participants would have come into the lab 25 times and completed 40 hours of cognitive training. For the expectancy questionnaire, at the end of the 12-week intervention, participants were asked again what TDCS group they thought they were in, and experimenters were asked to guess what group they believed the participant was in, either active or sham TDCS, to assess blinding efficacy. So before I get into the results of the overall ACT trial, I'm going to give a bit of background into cognitive training, which leads into my dissertation study. Numerous studies have shown that cognitive training can improve cognitive functioning with moderate to large effect sizes, although substantial variability exists. This is especially true within the domain of processing speed. Computerized training using the useful field of view task has shown practice gains up to 10 years following the trained task. Data from the ACTIVE study, one of the largest studies looking at cognitive training to date, has demonstrated that, unlike other cognitive training paradigms, proximal training effects using UFOV training are durable and long-lasting. UFOV training has also shown efficacy in near transfer, or transfer within the processing speed domain. Following UFOV-based interventions, improvements in other processing speed tasks have been shown. And of even greater importance, UFOV interventions have resulted in demonstrable real-world gains, known as environmental transfer. UFOV training has widely been shown to be related to improvements in driving and completion of instrumental activity in daily living, or IADLs. Although there's substantial evidence regarding the efficacy of UFOV cognitive training, there have actually been very few studies that have assessed the underlying neural correlates of this task, why this task is so efficacious. Shockingly, up until 2018, there were virtually no studies looking at the neural correlates of this task. One of the few studies at the time found that a UFOV-based intervention resulted in changes in bold activation in 8 ROIs. Furthermore, they found significant increases in resting state functional connectivity between several ROIs compared to a no contact control and an active control. We have also replicated and expounded upon these findings using the baseline ACT data. This study, led by my colleague Cheshire Hardcastle, found that resting state connectivity in the singular opercular network, or CON, and frontoparietal control network, FQCN, predicted performance on an adapted version of the UFOV task called the double decision task. Specifically, greater within-network connectivity of these two networks were associated with faster correct performance on this task. So this brings me directly to my dissertation work. I wanted to investigate the neural correlates of this task and see if we can improve performance on this task. Everything in my dissertation was within the context of the larger ACT study. And the first 2 studies I'll talk about were cross-sectional, and the last will be longitudinal or pre-post intervention. So again, my dissertation work looked at the neural correlates of this UFOV task. Again, briefly, participants saw the stimulus screen in which they must attend to an object in the center of the screen and a target in the periphery amongst distractors. And during the probe screen, they must make a forced choice response if the screen is the same or different than the previously observed stimulus screen. Our first objective was to see what areas of the brain are even implicated in this task. Thus, we wanted to assess bold activation patterns while participants were completing this task. So to our surprise, we actually found larger than expected differences in activation patterns between the stimulus and probe conditions. On the left, we see relatively strong and widespread activation during the stimulus screen when participants are viewing and encoding the stimulus, compared to much more focal activation during the probe screen when participants are actively recalling the previously observed stimulus screen. So these activation patterns were assessed while participants completed the task. We also assessed what areas of activation are essential for task performance On the left is the same activation patterns I showed previously when participants are encoding the stimulus. On the right are areas of activation that are also associated with task accuracy. Interestingly, there were no significant clusters associated with performance while participants were making the forced choice recall during the probe screen compared to the stimulus screen. So after we delineated what brain regions are activated and associated with task accuracy, we then wanted to see how these regions are functionally connected, if at all, during task performance. To do this, we created 10 spherical ROIs centered at the regions of peak activation during the stimulus screen that were also associated with accuracy. ROIs were titrated to ensure non-overlap. At this point, we had recruited 336 individuals, 233 of which were in the previous BOLD study on which these ROIs were based. We found that controlling for age, sex, education, and scanner type, connectivity within these 10 ROIs during task completion, specifically during the during the stimulus and probe screens, was associated with task performance. So not only are these regions activated with task completion, associated with task performance, but they're also functionally connected, communicating with one another to complete this task. Our next question was if this communication strengthens or changes with a TDCS and cognitive training intervention. And that's where the overall ACT study comes in. Of course, we weren't able to assess this until after the active versus sham TDCS allocation was unblinded at the end of the study. So I've provided here the consort diagram of the ACT study and for dissertation. Overall, we phone screened 2,437 individuals, 642 of which were eligible for an in-person visit. Of the 642, 439 individuals came in for the baseline visit. 379 were randomized to either active or sham TDCS, and 308 of which completed the intervention and returned for their 3-month visit. For my dissertation analysis, we analyzed neuroimaging data from 187 of those participants that completed the MRI at both time points. So here's the demographics and adherence for the overall ACT study. There were no differences in age, sex, race, ethnicity, or years of education between allocation groups, active versus sham TDCS. Participants were 77% adherent to simulation visits and 72.5% adherent to cognitive training visits. It's important to note that these adherence numbers were after a participant was randomized, regardless of whether they withdrew or not. So for instance, if a participant withdrew after the first 5 visits, they would be considered to be 8.3% adherent to cognitive training and 25% adherent to stimulation visits and would be included in this statistic. Of those that completed the intervention, adherence to both stimulation visits and cognitive training were above 90%. So of the participants included in my dissertation study, individuals who had MRIs at both baseline and 3 months, like the overall study, there was no significant differences in age, sex, education, or active versus sham allocation between the 2 sites, the University of Arizona and the University of Florida. And again, similar to the overall ACT study, approximately 2/3 of participants were recruited at the University of Florida and 1/3 was recruited at the University of Arizona. Chi-square analysis revealed no significant differences between active and sham groups on participants' probability of correctly guessing their own intervention assignment. Additionally, there were no significant differences between active and sham groups on the experimenter's probability of correctly guessing the participant's intervention assignment, suggesting that this served as an effective blinding condition. We found no significant differences between TDCS groups in sensations prior to stimulation or during stimulation. We did find significant differences between the sham and active groups in symptoms of visual changes, with the active groups endorsing slightly more visual change after intervention. However, I should note that this difference is 4/10 of 1 point on a 1 to 10 Likert scale. Thus, all the values that you see on the chart are quite low, suggesting minimal sensations in both active and sham TDCS. So using the 10 ROIs from the cross-sectional UFOB study, we aim to assess whether task-based connectivity changes differ between active and sham TDCS groups following intervention compared to baseline. Analysis were nearly identical to the previous study with the inclusion of UFOB change score as an active covariate, and group differences were modeled, i.e. active versus sham groups. So what did we find? Of the 10 ROIs, we found strengthened functional connectivity only between the left and right pars triangularis at 3 months compared to baseline. Moreover, this strengthened functional connectivity between these two ROIs only improved for the active group, as shown in red, where we evidence a slight decline in functional connectivity in the sham TDCS group in blue during task completion. What we found interesting was that functional connectivity only improved in the active group between the two nodes closest to the stimulation site. But how does this relate to cognition? Perhaps unsurprisingly, we see that individuals in the active TDCS group, shown in red here, showed significant improvements in task performance, whereas those in the sham TDCS group showed slight declines in performance pre to post intervention, controlling for age, sex, education, and scanner location. So following the completion of my dissertation work, I joined the Center for Vital Longevity here in August of 2023 to continue learning new skills, as well as to continue to research predictors of cognitive decline to inform research that may allow for interventions to improve cognition. So while my previous work had focused on functional activation patterns and task-based functional connectivity, one biomarker that I had not explored was white matter integrity. White matter integrity has been widely shown to change with aging. 3 commonly used metrics that serve as proxies for white matter integrity include fractional anisotropy, or FA, axial diffusivity, and radial diffusivity. FA is a measure of the directionality of water diffusion in tissue. It quantifies the degree to which water diffusion is more restricted in certain directions compared to others. Higher FA values typically suggest more organized and intact white matter fibers. RD is the measure of average diffusion rate perpendicular to the main direction of the fiber. So as you can see, lambda 2 and lambda 3. And it's the average diffusion rate perpendicular to the main direction. Higher RD values can suggest damage to the myelin sheath or demyelination. AD measures the diffusion rate along the main axis of the fiber, which corresponds to the direction of the white matter tract. Reduced AD values can indicate axonal damage. Regional white matter integrity has been associated with cognitive performance in numerous domains, including processing speed, work memory, episodic memory, and executive functioning. Studies further suggest that environmental factors may have been shown to impact white matter and cognition, such as cardiovascular risk. Thus, our goal for this study was to investigate the relationship between these metrics in the corpus callosum, the largest white matter tract in the brain. So for this study, we recruited 174 participants ages 20 to 94 from the DFW Metroplex. Blood pressure was measured for all participants, and pulse pressure was calculated as systolic minus diastolic blood pressure. Pulse pressure has previously been shown to be a good proxy of arterial stiffness. To measure white matter integrity metrics, we used deterministic tractography using the corpus callosum as our main region of interest and placed regions of avoidance at the mid-sagittal plane and cingulum. So moving into our findings, we found significant mean effects of age in FA, RD, and AD in the corpus callosum. Specifically, increasing age was associated with lower FA and higher RD and AD metrics within each segment of the corpus callosum. Additionally, we found a significant interaction between white matter integrity and age, suggesting that age may play a differential role in metrics of white matter integrity across each region. And one thing I want to note here is that there were 5 regions that we delineated: the genu of the corpus callosum, the anterior midbody, posterior midbody, isthmus, and splenium, as shown by these color-coded metrics here. Specifically, we saw decreases in FA with increasing age across all segments of the corpus callosum. However, looking at these lines, you can see that the slope of the relationship becomes less steep as we move more posterior throughout the corpus callosum. Likewise, we see a similar pattern with RD, with increasing RD with age. Like FA, we see the decreasing strength of RD as we move posterior through the corpus callosum. And not surprisingly, we find a similar pattern for AD as well. To the left is a circular bar plot depicting the decreasing strength of findings for all three metrics. The bar plots are plotted as the correlation coefficient for all aged by corpus callosum segments for FA, RD, and AD. So thus we see strong correlations with FA, RD, and AD in the genu of the corpus callosum, and they all become weaker as we move more posterior throughout the corpus callosum. Looking at pulse pressure effects, we found a significant main effect of pulse pressure on radial diffusivity controlling for age. Specifically, we found that higher pulse pressure was associated with higher RD values across the corpus callosum. Additionally, we found a significant age by pulse pressure interaction. Decomposition of this interaction shows that older adults above the age of 60 demonstrated that higher pulse pressure was associated with higher AD in the corpus callosum, where the same pattern of findings was not found for those under the age of 60. So with that, I'd like to conclude my talk. I'd like to acknowledge grants and fundings, my mentors, Adam Woods, Karen Rodriguez, and Kristen Kennedy, and everybody in the Woods, Kennedy, and Rodriguez labs. And thank you.
Thank you very much. Open for questions.
I've got a lot of questions. I'll limit myself to one.
Okay.
I'm really interested in the fact that the stimulation you used in the ACT study and previous was explicitly bilateral stimulation. You found increase in bilateral connectivity, and the lateralization or shift in lateralization is one of the possible mechanisms in older adults to facilitate functional recruitment. Do you think that's the mechanism of what's happening here? Or as a caveat to that, do you think you'd have a stronger result if you did unilateral single hemispheric stimulation?
That is a great question. I think that could be in part driving it. I think it is more activating the dorsolateral prefrontal cortex bilaterally while also engaging in cognitive tasks that activate that network. So essentially, tasks that activate more frontal lobe structures, we find that that's where we find greatest results. So if we were to put it, let's say, unilaterally, it would depend on the underlying brain tissue. So if you were to use like a unilateral montage, for instance, you may be targeting more motor areas as opposed to DLPSC. You may be targeting other regions.
The motor control is also correlated with retained cognitive function. So
yes,
in that region. It's an interesting question. Thank you.
No, of course.
Not really directed in your research generally, but an assumption in the stimulation fields. You mentioned at the beginning of your talk that the idea is to increase cortical excitability as being most likely target for improving cognitive function. But there's quite a lot of evidence that at least in cognitively healthy aging, one of the problems is actually a decline in GABA. In other words, there's a change in the inhibition excitation balance, which gives rise to hyperexcitability with age. So you would think, according to that idea, what you'd want to do is dampen excitability, not enhance it, because you want to compensate for the inhibition coming from reduced availability of GABA.
Yeah, that actually is a great point. And I'm going to go back to one of my previous slides. And you bring up a great point. So this was work done in context of the CogStim study. We did find increases in GLX, but also non-significant, but we did find increases in GABA as well. We did collect MRS for the baseline and 3-month visits. That actually has not been analyzed, but I think it would be interesting to take a look at how GABA also changed. Is it an increase in both? Is it just selectively increased GLX compared to GABA? And it might be that longer stimulation periods and longer interventions may alter this neurometabolic signature of TDCS.
Yeah, I think one little wrinkle is that the depletion of GABA is not regionally homogeneous.
Exactly.
So medial prefrontal cortex, I think, is a different profile than more posterior cortex.
Yes, and yeah, that's absolutely a great point. For this, we specifically wanted to look at the areas of stimulation, so between where the current was most dense, essentially. So that's why we placed it more anterior. But you're absolutely right. Like the absolute concentrations will absolutely change depending on where in the brain you are. So we were primarily looking at changes due to electrical stimulation.
I can't remember, did you associate this with cognitive performance?
So yes, so this was based on the STEM brain study, and we found that in that study there was increased feedback accuracy in the active but not in the sham groups. And additionally, in the active but not in the sham groups, we saw this increase in GLX pre to post.
Did the increase in GLX correlate with the better performance?
Yes.
Okay. In the GABA? Was it significant?
No, the GABA was not.
Okay.
Maybe I can jump in. For me, it was very interesting to know that it's just a 2 milliampere and not the 1 and not the 3. And I'm wondering what are your thoughts around that? How much do we understand? Why is it so specific to this milliampere? And also, when you did a very careful mapping of the how the scope basically altered, is it only by intensity, or does it also change something, the effective specific voltage that is undergoing through the skull?
Yeah, that's a great question. I'm actually going to answer the second one first. So the amount of current that reaches cortical tissue does impact cognition, and it is based, of course, on the individual anatomical differences here. So we found that those who had received more electrical stimulation in the areas targeted did have better performance post stimulation compared to baseline. Whereas those that had very little current reaching the underlying cortical tissue really exhibited no cognitive change whatsoever. To answer your first question, we really don't know a lot about why there are these nonlinear effects in TDCS stimulation. It's thought to be due to changes in sodium and calcium concentrations, but it really is not definitively known as to why this occurs. Yes.
Do you measure how much stimulation is being, and not just given, but you're saying that it matters based on how much is being absorbed from it? How do you actually detect that?
Yeah, so it is based on these individual tissue types. So basically we segment the entire head into 12 different tissue types and calculate the amount of current that reaches the underlying cortical tissue. So after going through skin, muscle, fat, compact bone, cancellous bone, how much of that is still reaching the underlying cortical tissue. So
An assumption based on you're not actually like measuring the electrical current.
Right. So we're not doing like intracranial measurements. We are basing this off known conductivity values of each of these tissue types.
Okay. So I've been out of the TDCS game for like 5 years, but what is the current report on the concern that the electro current is diffused throughout the brain, right? So do you have any active controls where you apply TDCS to a different location to show that it is location or region specific to help?
Not in these studies, we have not, but there have been studies that have shown like a lot of these current density maps do change when the electrical current, let's say, is at a different montage. Let's say another commonly current one is M1SO, which targets motor cortex and supraorbital frontal cortex. So there are differences in current density depending on where the electrodes are placed. And there is some diffusivity in electrical current, but we can see in these individualized current maps, the greatest amount of current tends to be between the anode.
It's quite clear, it's very diffuse.
Yeah, I mean there are patterns of diffusivity, and this is not focal TDCS. So there is a mechanism known as HD TDCS, which uses very small electrodes placed in very specific patterns. The sponges that we used were 5 centimeters by 7 centimeters. So that is quite large for the electrical stimulation. There was discussion on for these studies whether to use HD TDCS or the high definition TDCS, the very focal electrical stimulation versus more widespread stimulation. We went with the more widespread stimulation because we wanted to target as much of the DLPFC and frontal cortex as we could to hopefully try and stimulate.
Maybe last question. So for the study that you conducted for your dissertation, were you able to show different levels of transfer from those training or the cognitive training, or were you just focused on the cognitive training tasks themselves?
Yeah, I was focused more on the neural mechanisms of like the UFOF task and brain activation patterns while completing this task. But you do bring up a great point in that in this analysis, individuals that were assigned to active TDCS improved on the UFOF task, whereas those in the sham did not. And it's important to note that although the Brain HQ Cognitive Training Suite incorporated measures of processing speed, they did not use the exact task in the fMRI. So essentially, this suggests that their performance improved on this task, but this was not the trained task that they did during the 40 hours of cognitive training. So that does suggest some possible near transfer effects.
Any questions online?
Nope, no questions online.
So with that, let me thank you again, Jessica, for a really enlightening talk, and we all feel very happy to have you here.